Good morning, everyone. It's my pleasure to be here today, and I'd like to thank the conference organizers for giving me this chance. Our topic will be about the basal ganglia and what you, as a radiologist, need to know about. First, I have no disclosure, and my objectives are review the anatomy of the basal ganglia and illustrate the importance of clinical manifestation and clinical scenarios, classify the lesions, make a roadmap, and think systematically. Starting from the anatomy, the basal ganglia are deep gray matter structures that consist of the caudate nucleus, lentiform nucleus, substantia nigra, and finally the subthalamic nuclei. Subthalamic nuclei are not seen on MRI, so we will drop it, and for the sake of time, we will not talk about a disease of the substantia nigra, and we will keep to caudate and lentiform nuclei. Caudate nucleus are a comma-shaped nuclei that are seen along the lateral aspect of the lateral ventricle here, starting from the caudate region, which are outlined here in red, lateral to the frontal horn of the lateral ventricle. And on sagittal image, you can see the comma-shaped appearance of the caudate nucleus, starting from the head region, the body, and finally the tail, which is tapered posteriorly. On coronal images, they start larger in shape, like here in head region, and become smaller as you go more posteriorly. Lentiform nucleus is a triangular shaped nucleus that are seen lateral to the caudate nucleus, here outlined in yellow, and separated from the head of caudate by the anterior limb of internal capsule, and separated from the thalamus by the posterior limb of the internal capsule. It consists of two parts. The outer part is called the putamen, which is here outlined in orange, and the inner side part is the globus pallidus, here outlined in green. Note that the signal of the putamen is like a signal of the caudate and gray matter. However, the signal of the globus pallidus is much lower, and this is owing to deposition of iron, which is deposited in the globus pallidus, reducing its signal intensity on T2. And you can also appreciate these changes in sequences that are sensitive to the paramagnetic effect of iron, like here in diffusion emitted image. You can discriminate between the globus pallidus, which is low signal here, from the putamen, which is outside. Deposition of iron is a physiological process that starts at the age of 10. Before 10, you don't see such changes, like here in the 2 years old child. You cannot differentiate between the globus pallidus and putamen. And in 25 years of old, you can discriminate now from the globus pallidus from the putamen. And by advancing age, the deposition is more and more, and signal will be more and more decreased. The caudate and the lentiform are connected together by these striations of gray matter, as you can see here, and together they are called corpus striatum. The arterial supply of the basal ganglia derived from the M1 segment of the middle cerebral artery through the lenticulostriate arteries, and venous drainage to the deep system and to the internal cerebral vein, vein of Galen, and straight sinus. Function of the basal ganglia: it's a part of what's called extrapyramidal motor system, which control voluntary movement and planning and programming of complex movement. And to maintain its function, they are rich in mitochondria, and they produce a large amount of ATP. So they need oxygen, glucose, and some minerals like ferrous, copper, and manganese. And any depletion of one of these elements, or sometimes excess of this element, will result in damage and injury to the basal ganglia. So let's talk about pathology of the basal ganglia. And before we talk about pathology, I'd like to tell you about the clinical manifestation. Is very important, and it can guide you to reach a final diagnosis. For example, I'll give you these are two patients. Flare images from two different patients, and both of them has a similar lesion, which are in high bright signal within the globus pallidus, bilaterally and symmetrically. But if I'm telling you that this patient is neurologically free, and he came complaining of some brownish spot on his in his trunk, and you look at the T1 weighted image, you find this lesion to be slightly hyper-intense or hyper-intense rim. They call it bright spots, or a new terminology is fuzzy, which is focal area of altered signal intensity, and we are dealing with a neurofibromatosis type 1. On the other situation, this patient is 25 years old who found unconscious in his bathroom, and you look at the diffusion weighted image, there is bilateral diffusion restriction in the globus pallidus. These are actually infarction within the globus pallidus, and you know you are dealing with a carbon monoxide poisoning. So two different patients, similar finding, however, these are two different clinical manifestation and two different outcome. Trying to classify the basal ganglia lesion, we can classify them into two categories. The first category is the bilateral symmetrical lesion, and the other category is unilateral or asymmetrical, which led to another group of diseases. Bilateral symmetrical, we can further classify into lesions with high T1 weighted image signal and lesion with high T2 or flare weighted signal. Also, high T2 flare disease will be further classified into child and neonate, and these which affect the adults. So let's start by high T1 signal intensity lesions. Here is a T1 weighted image of a patient who had this hyper-intense signal within the globus pallidus bilaterally and symmetrically. There is no corresponding lesion in the flare images. And you know that this patient has advanced liver disease. And this high signal, it is attributed to a high serum manganese level, which bypassed the diseased liver and deposited within the globus pallidus bilaterally. And here is a paper which talk about the manganese neurotoxicity and its deposition within the globus pallidus. And you know that this patient has liver cell failure. Also, patient who underwent TBN or received total parenteral nutrition can show similar changes from also from manganese deposition. But this patient has a similar lesion here, which are hyper-intense signal within the globus pallidus and also in the dentate nuclei of the cerebellum. And this patient has no liver cell failure and he didn't receive any TPN. But after taking history, you will find this patient has multiple MRI scans before with gadolinium contrast. And you know that this is a gadolinium deposition. And this is a paper from radiology talking about the intracranial gadolinium deposition. So far, we don't know what it can do neurologically to these patients. Another patient here, another scenario, the patient had bilateral bright T1 signal in the caudate and lentiform nuclei. And if you do a CT for this patient, you will find an extensive calcification within the lentiform nuclei and also in the caudate and subcortical white matter and also the dentate nuclei. This patient has pseudo-hypoparathyroidism. Similar to finding you can see with patient with Fahr syndrome. And why this lesion appear hyper-intense signal on T1? It's attributed to crystalline form of calcification, which alter the relaxation time of water molecules and give this abnormal signal. This is another patient who had bilateral symmetrical abnormal T1 signal intensity within the putamen only, okay, and a slightly increased signal within the lentiform nucleus in the FLAIR images. And from the clinical history of the patient, you find this a 35-year-old female who had a poorly controlled diabetes mellitus, and she typically came with choreic movement in her limbs and sometimes hemiplegismus also. And you know that these findings are consistent with non-ketotic hyperglycemia. Moving to the other group, which are high signal intensity in T2 and FLAIR disease, and the first and the most important one is the hypoxic ischemic encephalopathy and its related conditions. And these depend on the age of the patient and the duration of the ischemia and also the severity of this ischemia. This is a preterm child who was subjected to moderate form of hypoxia, and as you can see, there is a hemorrhage between the caudate and the thalamus. This is the caudothalamic groove, periventricular hemorrhage, and it can be appreciated more in these sagittal images. And from the location and from the preterm age of this patient, you know that this patient had a germinal matrix hemorrhage grade 1. More advanced case of germinal matrix hemorrhage with intraventricular extension and dilatation of both lateral ventricles with CSF and blood level, as you can see here. This is a germinal matrix hemorrhage grade 4. Another form of hypoxia in a full-term patient who has subjected to severe hypoxia, and this pattern is more central. You can see there is signal intensity, abnormal flare signal intensity within the lentiform nucleus, within the thalamus, and also in periorlandic area of the cerebral cortex, and you know that it's a hypoxic ischemic encephalopathy in full term. If the hypoxia is very severe and prolonged, the child may show such appearance, which is complete loss of gray-white matter differentiation and hypodensity of the brain, so that the sinuses become more and more hypodense. And if the patient survives, his brain will develop what's called multicystic or polycystic encephalomalacia, multiple area of CSF within the brain, and this is a cerebral palsy patient. Moving away from the ischemic lesion, this is the 2-year-old boy who has delayed developmental milestones and ataxia and hypotonia. And this is the FLAIR images of his show bilateral symmetrical thalami and putamen abnormal signal with some in the white matter also. There is also affection of the dorsal brain stem and dentate nuclei bilaterally, and all these lesions show diffusion restriction on DWI. If you do a spectroscopy for this patient, you will find a very large peak of double peak of lactate on 1.33 peak, and this is lactate peak, high lactate peak, and this you are dealing with patient with Leigh disease. So in Leigh disease, there is a mitochondrial defect and there is abnormal production of the ATP. So the patient will go into an anaerobic metabolism. Another patient of Leigh disease here, this is an older child who is about maybe 5 or 6 years old, and there is bilateral symmetrical caudate lentiform and also dorsal midbrain, which is a very characteristic location, and also diffusion restriction on DWI. Another patient of Leigh disease. Changing from young to adults, and this is a 25-year-old male came with confusion and blurring of vision, and you see a bilateral asymmetrical hypodensity within the lentiform nuclei and subcortical region of the frontal lobes, and in T2 in flare weighted images, you can see the bilateral symmetrical hyperintensity with some edema and also subcortical changes. And there is diffusion restriction, and these are mainly in the putamen. There is bilateral putaminal necrosis, and this patient of methanol toxicity. Unfortunately, this patient went blind after this study. Another similar lesion, which are bilateral symmetrical in the caudate and putamen. This is a 50-year-old with chronic renal failure and came with disturbed conscious level. And on MRI, the T2 weighted image, there is bilateral symmetrical hyperintensity of the caudate and lentiform, but there is characteristically the lentiform is outlined by a more hyper-intense signal here. This is more appreciated here in the FLAIR images, bilateral outlining of the lentiform with a hyper-intense signal, and this is called lentiform fork sign, which is edema of the external and posterior limb of internal capsule outlining the lentiform, and you are dealing with a patient with hyperuremic encephalopathy. Another situation here, there is a 45 years old male diabetic, and he has a generalized seizure and followed by a coma. As you can see on diffusion weighted image, there is bilateral symmetrical cortical and subcortical diffusion restriction, also affecting mainly the parietocortical and frontal cortex with caudate and putamen, and also semi changes in FLAIR images, and you are dealing from the history and from the finding you are dealing with hypoglycemic encephalopathy. This is a different scenario here, demyelinating disease which can affect the basal ganglia. You can see here abnormal signal within the bones, but sparing the anterolateral aspect of the bones, which are the location of the corticospinal tracts. And these changes are also seen in the lentiform nuclei and caudate nuclei, and you are dealing with osmotic myelinolysis. This is a pontine and extrapontine osmotic myelinolysis, and these patients are typically either patient underwent rapid correction of hyponatremia or chronic alcoholics or malnourished, and this changes from electrolyte imbalance. Also, another lesion affecting the brainstem, as you can hear, but doesn't spare the corticospinal tract, also affecting the thalami and the lentiform and the caudate nucleus. This is a 6-year-old child with ataxia and gait disturbance. And by doing examination and more investigation of the patient, you will find the patient has ceruloplasmin deficiency, which is a carrier of copper. So copper is free inside the blood, and serum copper will elevate it, and it will deposit in the brain and liver and cornea, causing hepatolenticular degeneration. And we are dealing with a case of Wilson disease. A characteristic appearance of Wilson disease is what's called a giant panda face sign, but it's not always always in the disease. Unfortunately, you can see the hyperintense signal within the brainstem and the midbrain, as you can see, sparing the red nuclei, which are the eye of the giant panda. Moving to the other group of disease, which are unilateral and asymmetrical affection. Starting from the variants, we have here cystic areas within the basal ganglia bilaterally. They have a similar appearance of the CSF, and this is very common, which is called dilated Virchow open spaces. Sometimes the dilated Virchow open space or perivascular space are very large, and sometimes they can cause a mass effect, as you can see here. And this is a nice paper from Radiographics talking about the Virchow open spaces and its types, so you can read if you are more interested. Ischemic lesion can affect the brain and the basal ganglia as well, like here, for example, from occlusion of the middle cerebral artery. There is infarction of the frontal lobe and also involving the lentiform nucleus, and here you can see the occlusion of the middle cerebral artery from the ME2 segment in MR angiography. Also, sometimes the infarction become hemorrhagic, as you can see here. This is a right MCA infarction, subacute infarction with associated hemorrhagic transformation in the lentiform nucleus in the basal ganglia. Some infections also favor the site of the basal ganglia, like here, for example, you have slightly hyperdense lesions in the right basal ganglia with associated marked edema. On MRI, these lesions are hemorrhagic, as you can see here, with associated also edema and also mass effect. And by post-contrast scan, you can see this lesion to have a regular marginal enhancement. They are more than one lesion, and this is patient has HIV. He is HIV positive, and these are toxoplasmosis. Also, some neoplasm favor the location of the basal ganglia, like here, for example, these are lesions which are hypointense on T2 and surrounded by edema. They also display diffusion restriction on DWI, again on DWI, and finally they have homogeneous and strong enhancement following IV contrast and administration, and this was primary CNS lymphoma. So our take-home message from this talk is clinical manifestation is very important to make a diagnosis and try to interpret the clinical situation or manifestation with the imaging finding, review all imaging modalities, try to narrow your differential diagnosis, and finally follow up your cases and get feedback. Thank you, and I hope you enjoyed.